Good afternoon, everyone. Thank you all for joining the TxRx Echo brought to you by the Center for Substance Use Training and Telementoring, also known as CSTAT, by BeWell Texas in collaboration with the UT Health San Antonio Echo program. My name is Angela Riley, and I will be the facilitator for today's session. A few housekeeping items before we begin. Please introduce yourself in the chat by entering your full name, affiliation, and email. Please do remember to stay muted unless you are speaking. We encourage using the chat and or the raise your hand feature to pose questions and share perspectives throughout the session today. We would love to have everyone with their cameras on as this does increase connection and engagement, though we do completely understand that some situations don't allow for that. So, however, if you are able, please turn on that camera. We'd love to see your lovely face. If you are having connection issues, please privately chat Karen, our wonderful Echo IT, for further assistance. As a note, these sessions are being recorded and they will be shared on our website. Therefore, to ensure privacy, no personal health information is allowed at any point throughout the session. This includes names, addresses, birth dates, and any other identifiable information. Additionally, the slide presentation for today's session will be uploaded and shared on iEcho for your reference in the future, and it will also be shared in a post-session communication email. At the end of the session, the Echo team will be sending out a post-session survey link. We kindly ask that you complete it as it does provide us really great feedback on how to refine these Echo sessions to better address your priorities and your interests. And finally, Echo is an all teach, all learn environment, and we encourage everyone to participate in today's conversation. And may we always make every effort to continue having the space that's respectful and safe for all of us to learn together. With that, we'll move on to some team introductions. I'll begin with Dr. Kowalczyk.
Hi, I'm Alicia, Dr. Kowalczyk here at Baylor College of Medicine, Family and Community Medicine, Addiction and Family Medicine boarded. Thank you. Welcome.
Thanks, Dr. Kowalczyk. Dr. Shorter.
Hey everyone, Daryl Shorter. I'm also at Baylor College of Medicine in the Department of Psychiatry. I'm an addiction psychiatrist and medical director of addiction services at the Menninger Clinic. Thanks.
Thanks, Dr. Shorter. Dr. Walker.
Good afternoon, everybody. Crystal Walker, doctorally trained PA and the Director of Substance Use Disorders Clinical and Medical Services for MHMR of Tarrant County in Fort Worth, Texas.
Thanks, Dr. Walker. Dr. Waklu.
Good afternoon, Siddharth Waklu. I'm an addiction psychiatrist at UT Southwestern in Dallas, the interim chief for the addiction division and the director for the addiction psychiatry fellowship here at UT Southwestern. Welcome, everyone. Thank you.
Thanks, Dr. Waklu. Our lead specialist for today, Dr. Chaudhary.
Good afternoon, everyone. I am Muhammad Ali Chaudhary, and I am the Director of Adolescent and Youth Clinical Services here at BeWell, Texas, in San Antonio.
Thanks, Dr. Chaudhary. And our didactic presenter for today, Dr. Blair Walker.
Hi, everybody. Thanks for having me. I'm a psychiatrist with University of Texas Dell Medical School. I work at mainly Dell Seton Medical Center, and I'm boarded in psychiatry, consultation lead on psychiatry and addiction medicine.
Wonderful. Thank you, Dr. Walker. And Dr. Landis, our case presenter for today.
Hi, everyone. I'm Dr. Laura Landis. I'm a PGY3 in internal medicine, also at Dell Seton Medical Center in Austin.
Thank you for being here, Dr. Landis. And thank you to everyone that has introduced themselves so far in the chat. I do see more intros coming through, so keep those coming. Let us get started with our didactic presentation for today. Dr. Walker, you may take it away.
Great. Can we share the slides? Awesome. Hi. So I just introduced myself. I'm Blair Walker. I mostly work at Dell Seton Medical Center, which is a level 1 trauma hospital. There's a safety net teaching hospital in Austin. We have a burn unit. And so because of those more than a decade of work here as an attending, have developed some expertise with taking care of patients with opioid use disorder. So thanks for having me. I can go to the next slide and our attributions. just a shout out to John Weems, who's an addiction medicine doc here. This is sort of a tweaked lecture from several years ago that we gave together. And then disclosures. I don't think anyone else has anything to disclose. You can go to the next slide. I have nothing to disclose, and neither does anyone else. And just to remind everybody that all of our opinions expressed are specific to the speakers and individuals, and not a part of UT Health San Antonio or ECHO specifically. So here are our learning objectives. Hopefully you've had a chance to see them already. But we're going to talk about this as being a really great opportunity to help patients with opioid use disorder and offer opioid use disorder treatment when they're sick and in the medical hospital. That's sort of the paradigm that I'm talking about today. Recall that opioid use disorder medication typically shouldn't be stopped perioperatively, and just understand how important it is to treat pain optimally, I would argue even aggressively, in this population, including potentially offering high-dose opioids, which is a common mistake that we sometimes see. So you can go to next slide. So these are some pain and opioid use disorder myths that maybe we'll talk about busting while we're doing this lecture. So just a myth that in opioid use disorder, opioids are ineffective for pain. Buprenorphine and methadone for treatment of opioid use disorder will treat pain, maybe, depends. Buprenorphine and methadone block all opioids, a myth. That it's illegal to prescribe opioids for pain to patients with opioid use disorder, also a myth, as long as they're on treatment. Opioid use disorder always equals relapse risk. So just things to think about as we go into this. You can go to next slide. The idea of treating pain and opioid use disorder that gained over the years is I recommend always engaging in every interaction with autonomy and dignity. It's all about engaging patients, being transparent, and I sort of teach the philosophy of like a platter of options, and then just really reviewing the risks and benefits of the different things, but let patients decide what they choose within your boundaries. There's no wrong door for addiction treatment, meaning if somebody really, really, really wants to be in a certain regimen and it's a reasonable one, it's okay for them to choose it, even if it makes things more complicated or makes things more difficult in disposition afterwards, for instance. And then the last one is just be curious and avoid anchoring. I always develop differentials for when you're having really challenging behavior. For instance, not just drug seeking and someone's being malicious, but why? What's going on that's making them need or ask for more medications? Is it just substance use disorder? Is it a substance use disorder you don't know about? Are they in withdrawal? Are they in terrible pain that's not being treated? Distress from some other reason, or just from being in the hospital, being sick? Are they having sleeping issues? Think about trauma, and is there a diversion? To always think about that as a side concern. Next slide. So 3 FDA-approved medications. We'll go through them over the course of these few slides very briefly, but methadone, buprenorphine, and naltrexone. You can go to the next slide. I think you have to click a few times. Yeah. So methadone being our full mu agonist, it has the best evidence for treatment retention, and you don't have to be in withdrawal to start it. So same within the hospital. It's administered for opioid use disorder only in the outpatient narcotics treatment programs. So one of the downsides is that you can't prescribe it to patients when they leave, and that's sometimes a choice that someone is kind of taken into consideration. There are lots of drug interactions, and there is a higher risk of respiratory depression and overdose. Buprenorphine, partial mu agonist. I know you guys have gone through all of this before, but often prescribed with naloxone. It's office-based. It does theoretically have a lower risk of respiratory depression if you're not mixing with other sedatives, and maybe a lower diversion risk. But the downsides are precipitated withdrawal, and there's a lot of fear about precipitated withdrawal, even in the hospitals. And theoretically maybe lower treatment retention, but it also makes disposition after discharge easier. It's often in most of our communities, I don't know what it's like in the other ones, but in Austin, it can sometimes be a lot harder to connect with methadone clinics rapidly. And then the last is naltrexone, a full agonist. It's a monthly injection. may, also helps with alcohol use. The concerns are maybe doesn't have as good evidence, and people have been fully withdrawn to start it and have lost opioid tolerance. So the overdose risk is more significant. So go to next slide. It's just a way of thinking of these. You can go to the next slide. You guys have probably seen it before. This is a nice framework of just thinking about how to manage pain in the setting of opioid use disorders. You start with the patient and, what are the indications for the pain, dosing, formulation, their prior experiences, medication intolerances, looking at the acute pain itself and what that looks like. Is this a planned elective surgery? Is this emergent that just fell in your lap last night? What is the environment that you're in? Do you have an anesthesia service that can help with regional anesthesia and things like that? So it's just a nice way of thinking about it and how it overlaps to help guide someone in what their options are. You go to the next slide. So the general principles that I suggest are, especially first and foremost, treating withdrawal as rapidly as possible to avert an AMA discharge and improve pain management. And then just asking the questions and exploring. And a lot of times this is sort of like my initial intake that might be really, really brief. They're miserable and in withdrawal, and I'm already ordering something and have examined really quickly. Then I keep on asking questions while I'm waiting for the medications to arrive. But, are they already on treatment for opioid use disorder? What is it? Where do they get it? All the details of that. They're usually going to need additional opioids or dose changes in addition to the non-narcotic options that we'll talk about in order to manage that acute pain. Plus minus buprenorphine and methadone, they can be good options for pain control, and it really just depends on the patient's situation, whether or not they're on it already, if you can split the dosing and things like that, we'll talk about. Remember that offering opioids will not worsen a patient's substance use disorder. And in fact, if they discharge and go overdose on fentanyl and die, we've lost. So, treating pain aggressively is going to help them retain and get the help that they need. And then anticipate high opioid tolerance and potential need for much higher opioid dosing than you might typically offer, and helping kind of ameliorate some of the fear among staff that are bringing much higher than they're used to, triple the dose of an opioid for acute pain. So you can go to the next slide. These are just, some of the questions that you can ask about that. And then thinking about their preference, their prior experiences, offering guidance, and then thinking about multimodal adjuncts, NSAIDs, Tylenol, gabapentin, what can you offer in addition to help cool things off, both from an anxiety of the pain, anxiety of withdrawal, but also treating the pain itself. Always, if you have the ability to do this, involving anesthesia, considering regional or local nerve blocks, if it's an option, depending on where the pain is. And then I have a question mark next to ketamine. There's mounting evidence that intraoperative ketamine can spare opioid use both during and potentially after surgery. We have a lot of patients in our burn unit, which is excruciating pain, and often, like almost all the time, but definitely with dressing changes. And there's a lot of mounting evidence that it can really reduce pain, spare needing quite so much opioid, and help people feel better. So just keep that in mind. Next slide. So for acute pain management with methadone and buprenorphine, always continue their home dose, but make sure you're confirming the dose. You're checking PMP for buprenorphine. You're calling their narcotic treatment program to confirm the methadone dose, and they're open 6 days a week. Usually calling first thing in the morning is the best time, but they leave kind of early afternoon in most places. Also think about, the person who's prescribing their outpatient meds or giving them in the methadone clinic might have some great expertise, and they can guide you in how to help manage their pain if you need additional guidance, and especially if you're in a setting where you don't have the luxury of somebody like me that you can call for guidance in the hospital. Always consider splitting dosing. Again, working with the patient what they're willing to do, but you can sometimes see breakthrough pain later in the day, for instance, for somebody who's on large dose of methadone that's only in the morning. Maybe there's room to split some of it to 3 times a day or twice a day, just to give a little bit of the edge off later in the day. And then always consider the full agonist opioids if the patient's willing. You will come across patients who are absolutely not willing to take any additional opioids and don't feel comfortable, and then you should work with them on that and how to avoid opioids, including in the operating room if that's their choice. You can go to the next slide. And click through, yeah, great. So just keep in mind with methadone, yep, you can click through all of that. Consider the split dosing, we talked about that. Remember risk of QT prolongation, drug-drug interactions, and always caution with other agents that are sedating because they synergize. And especially when you're getting up to doses of 90 plus in a day of methadone, you're at higher risk for getting very significantly sedated. I've had patients, for instance, with a little extra Seroquel, and they ended up having some serious problems with being too sedated. And then just reminder, no prescription on discharge. Those of us who do this know this, but your colleagues might not, because anyone can prescribe methadone for pain. They might accidentally give them a prescription when they shouldn't, depending on what it's for. And just keep in mind, methadone stacks up. It has a stacking effect. It takes 4 or 5 days to hit steady state when you're changing the dose. And so say someone comes in on, 90 a day, you split it to 33 times a day, and they don't want extra opioids, or they do, but they'd like to cheat up their methadone a little bit. Be cautious, 10 to 15 milligrams max, but then you want to wait several days to make sure you're seeing what the effects are, because you will not see them in the first couple of days, and they can be oversedated quite significantly if you're too aggressive and increase the dose too quickly. So you can go to the next slide. I'm going to skip this slide, actually. It was supposed to be hidden, but it's just a way of starting somebody on methadone. So you can go next slide. So considerations on buprenorphine. Again, it's a partial mu receptor, but it's high affinity, low potency, and it dissociates slowly. So it grabs on tightly, and it definitely can compete with other opioids, and does. You will see precipitated withdrawal if someone is tolerant and hasn't gone into any withdrawal yet. But it's very easy, and usually people will withdraw fairly quickly. People live in fear of precipitated withdrawal. Always think about split dosing. And analgesia really can be helpful. 3 times a day, buprenorphine, sometimes 3 times a day, plus additional buprenorphine, depending on the dose that they need, can be really helpful for pain. And I have plenty of people that don't have super severe pain that do really well with only buprenorphine. Just a reminder, hopefully everyone knows this by now, but you definitely don't need extra training. There is no X waiver. Anyone who can prescribe DEA Schedule III can prescribe buprenorphine, and it's really easy to use. It's very well tolerated for mild to moderate pain. There is some suggestion, and depending on the person, I don't automatically do this, but if someone is on a higher dose of buprenorphine, 16 plus, you can consider dropping the home dose, but never stopping it, to try to allow for full agonist opioids to better compete with the buprenorphine. I usually wait and see, and again, have very patient-centered conversation with person. What do they want to do? How is their pain? What do they need? But on the right here, you can see just a nice slide about this idea of, is there a bit of an analgesic sweet spot on buprenorphine where there's doses between, 5 to 15, somewhere in there, it frees up enough receptor availability to allow for the other opioids to work a little bit better. Go to the next slide. And we can skip this slide, although I will say one of the main things that I come across with buprenorphine when I'm sort of offering buprenorphine, selling it, so to speak, is a misunderstanding of the naloxone added to it. I tend to be very permissive in our system about whether or not somebody needs to be on Suboxone versus Subutex, or buprenorphine naloxone versus just straight buprenorphine. And the clinic system in our area has about 10% of the people allowed to be on just straight buprenorphine by preference. They're a little bit more sensitive maybe to the naloxone that's embedded in it. But there's also a lot of misunderstanding about the naloxone being the thing that precipitates withdrawal, and so they will not choose not to take the combo product. And so I do a lot of education in the room about that. And again, follow the patient, let them be my guide about what they're willing and want to take. You can go next. Same thing, we'll go next slide. I'm trying to stay on time. So just the only thing I can say about long-acting naltrexone is that it's long-acting, it's in their system. If they've just gotten their injection, pain control is going to be challenging. You're going to need full agonist opioids, and it can be erratic and controlled one day and then not as controlled the next day. So just, I think the main thing is kind of asking for some grace and working with the patient and just doing the best you can, and definitely using kind of multimodal options to help manage pain as best you can. And if you have the ability to foresee, for instance, procedures, and working with a plan of how you're going to manage that. You can go to the next slide. So non-opioid strategies, again, a lot of hospital systems now have multimodal pain control, like power plans with lots of different options. But just think of all these different ways that you can really take the edge off. Patients give, sort of scoff at Tylenol, but I encourage them to just take it. It takes a little edge off. And if we can take a little edge off from this angle and a little from here, it'll all work together to help you feel better and tolerate this. So, Tylenol, NSAIDs, if you can, depending on their kidney function and their situation, nerve-related pain, and using like gabapentin or Lyrica. And then we talked about local and regional anesthesia, ketamine. Do benzos make sense in certain patients? They can. And so again, kind of being permissive, all with the aim of retaining patients in care so they can get the help that they need. You can go to the next slide. And so this is another kind of framework. It's from the British Journal of Anesthesia, but our anesthesiologist colleagues think about having conversations. I like this because it mentions, some ways to spare opioid use intraoperatively. And this is a little on the old side, but even still talking about ketamine, which has more and more mounting articles suggesting its use during the procedure that helps them use less opioid. You will have some patients that are absolutely adamant they don't want anything else than their methadone or their buprenorphine. They don't want to be exposed to it, even if they don't know they're being exposed to it, that they don't want their brains exposed to it because they're worried that it will trigger a return to use. It just gives you an idea of the different options that your anesthesia colleagues might be able to help with. So you go to next slide. So just to recap, I always recommend, and I'm sure all of you as well, just being very patient-centered and communicative, very flexible within reason. It will always serve you and your patients, help them trust you, help them be willing to stay for care. Buprenorphine and methadone can treat pain in certain situations. Always call their outpatient prescribers, let them help you too. Address withdrawal as rapidly as possible. Definitely use multimodal agents. And last but not least, don't forget the Narcan on discharge. I'm sure you guys talk about that a lot in these echo sessions. I'll open it up to questions. I think we're on time.
We are on time. Thank you so much, Dr. Walker. And Dr. Walkley, start us off with some questions for Dr. Walker, please. Thank you.
Dr. Walker, this fabulous presentation. Loved it. This is great. I just have a few questions. One was, on the ketamine, do you do it yourself or you get the help of anesthesia colleagues to do it?
It's a great question. In our hospital system, usually we're not managing the drip. It's not necessarily anesthesia though. It depends on the service. Our burn service, so because they have presence both in the surgical ICU and on the floors, we'll sometimes do kind of ketamine drips. They usually are in charge of it, but we guide a little bit. It's always sub-anesthetic doses. We're not trying to put people to sleep. We're definitely hoping that they're not hallucinating. But yeah, it's definitely a challenge in our system too. Our floors don't like us to do drips, even like a ketamine infusion that's brief, that's not for what we're talking about, but is for instance, depression. We've had these conversations about having to move people to the ICU. So we're trying to work that out actually lately. It just depends. And then, there's intraoperative ketamine, and only using it intraoperatively is another way that you'll sometimes see, or just brief ketamine prior to like burn dressing changes and things like that.
So that's done by the service, the dressing changes by the primary team, not by anesthesia, not by you. The primary team does it. Okay.
Right.
Okay. All right. Thank you. The second is, what if patient's drug of choice is fentanyl? Then how does your management of methadone and bube vary for controlling pain? Let's suppose they've been smoking fentanyl and they come in with to the trauma unit. How does that change?
Meaning just like in the context of high tolerance, or the fact that they'll withdraw a little bit later?
Right, height or both, yeah.
Yeah, I mean, again, I still kind of give them the option. What do you want to do? And kind of talk them through the options. We do a lot of short-term opioid bridging. And again, this was about, pain control. So most often I come and they're already getting a lot of opioids and maybe they just need the doses turned up. But we'll often do what we call sort of opioid bridging. So full agonist, short-acting opioids for a couple of days if they're going to be there for a while before we start to kind of plan for instance, buprenorphine initiation. If they want to be on methadone, they're convinced, they know the ins and outs of it. They're recently established with a methadone clinic, or they don't care about the whole after planning, like discharge stuff. Then, we get methadone going and we keep full agonist opioids going at the same time. Because again, we talked about the stacking effect. So, we're managing pain with short acting ones while the methadone's starting to kick in. A thing about methadone use is also like the disposition. So if someone comes in with a terrible car wreck, so that's one of the things that we see a lot of. What are they going to need after? And then do you have a system in your community that allows someone who's not yet established with a methadone clinic to go to a skilled nursing facility or an IPR? And we've had after COVID, we had some help with that, and then it sort of pulled back where it's harder to get people established. And so sometimes it's sort of guiding people and maybe more firmly guiding them. You're in for a long haul and we don't know if we'll be able to place you. We have the luxury in our hospital system of having a lot of tiny community hospitals. So we do have the option that if methadone is the right choice for the patient, to transfer them for like post-acute care recovery to one of our small community hospitals and get physical therapy. We call it a swing bed. And it gets around that a little bit, but it's not ideal. There's still a lot of regulations that make things harder for everybody, for patients.
And you talked about dropping the bube dose sometimes. What percentage do you drop it by? Or is there a formula, or is it a clinical
not even a
response?
formula, sort of just clinical choice, and always very, involving a patient. And a lot of times I say, let's wait and see how you do with it with all these opioids we're giving. Most often you give enough of the full agonist opioids, you don't need to do anything with the buprenorphine dose. I will say with the caveat of always keeping in mind, we talked more about drug interactions with methadone, but as a psychiatrist, I'm also often seeing people with a lot of comorbid psychiatric problems and might be on multiple different serotonergic medications. I have had serotonin syndrome cases with high dose buprenorphine and nothing else except for underappreciated liver dysfunction or something. And we've definitely seen it with other serotonergic medicines. All opioids are serotonergic. So it's always something to just keep in mind when you have people on high doses of everything. They start to get twitchy and confused. Some dose needs to change.
And my last question is on the non-opioid combination. You don't use SNRIs?
We do some.
Okay.
It's not like my first jump, but more and more, to be honest, I probably should add it in. It is something that we do consider, and it sort of depends on what they're on otherwise. There's actually some pretty decent evidence that duloxetine and venlafaxine really can help with pain. And so it depends on the person. We offer it. I feel like anecdotally, a lot of our patients just don't like that idea and tend to turn it down pretty quick.
Thank you so much. Once again, a great presentation.
Thanks for those questions, Dr. Waklu. Any questions from the audience for Dr. Walker?
Well, thank y'all for having me. I'm going to stick around for the cake.
Wow, I was muted. Thank you, Dr. Walker. If anyone has any questions I think of later for her, you can drop those in the chat, and Dr. Walker, just in case something comes through, I'll point your attention there. Thank you. We will go ahead and move on to announcements. Karen, when you can you please share those slides? Thank you, ma'am. To claim your CME credits for today's session, please ensure you have a registered account and then text attend 10100-862 to 844-502-1338 no later than midnight tonight. When you complete our post-session survey, you are helping us shape these sessions around your needs and your interests. This series was created for you all, and your feedback truly matters to us. We take it into consideration greatly. Your ideas, experiences, and suggestions guide how we plan our curriculum. And so please do complete that post-session survey. We're listening, and your input does help us improve this series for you all. Thank you. Next slide. CSTAT offers you all the opportunity to present a challenge your organization is encountering and to receive live feedback from our hub of experts and the broader learning community. We'll see our case presenter do this here shortly. So there is no need to prepare a formal presentation, as we do provide you with the form to fill out, and our hope is that this assists you with your case presentation and helps make that process seamless and easy for you. If you are interested or know someone that may be interested in presenting a case, please email us using the link that Karen will share in the chat. Thank you. Next slide. The Center for Substance Use Training and Telementoring by Be Well Texas is still accepting applications for the Mood Mentoring Program. This exclusive opportunity is for Texas Public Health Region 8 prescribers to receive personalized one-on-one mentoring to integrate mood services into their daily practice. If you are interested in participating in the program, please visit the application link that will be shared in the chat, or reach out to us using the email that's shared in the chat. Next slide, please. Thank you. The Texas Substance Use Symposium is back on March 2nd and 3rd of next year in San Antonio, Texas, and we're thrilled to reunite our statewide community once again at this really great event. For the latest updates, please visit the website that is shared in the chat to stay connected. Next slide, please. Thank you. And please join us for our next session, kicking off our Vulnerable Populations series, working with unhoused individuals, presented by Dr. Crystal Walker on September 11th. Thank you, Karen. And now we'll move on to our case presentation for today. Dr. Landis, the floor is yours. Thank you.
All right. Well, thanks for having me. Again, I'm Laura Landis. I'm a third-year internal medicine resident at Dell Seton Medical Center. I think I have a pretty fun case for you guys today. Excited to get some expert feedback as well. Okay, so I am presenting a case of a 43-year-old male. Also, do we need the slide up? I wasn't prepared to share that slide. If maybe someone from IT can. Perfect. Okay, wonderful. But I'll just mostly talk through the case. I have a 43-year-old, sorry about the wrong age there, but 43-year-old male. He had a history of opioid use disorder, as well as benzodiazepine use disorder and depression. And he presented to our hospital with severe agitation and delirium. So some background on this case. This gentleman's opioid use disorder started 13 years prior to his presentation. In 2012, after his primary care doctor prescribed him combined hydrocodone Tylenol, after he had a significant motor vehicle accident with significant back injuries and back pain. And he was not aware of the addictive potential, took the opioid around the clock, and his primary care doctor continued to prescribe it for years for him. In terms of his benzodiazepine use, that was even prior to that. So he used benzos starting in 2008 again, prescribed by his primary care doctor for anxiety. Was not aware of the addictive potential of that medication, took it around the clock, and developed a dependence quickly. He did go to rehab for benzo use in 2009 and was actually in remission for many years, but then relapsed in 2022. And so had been using both opioids and benzos pretty regularly for 3 years when he presented to our hospital. So he had gone to an outpatient, an inpatient recovery detox facility, not the hospital, to try to get medical treatment for his opioid and benzo use disorder. And he was there for 7 days, given a 5-day low-dose phenobarb taper, and then a 7-day buprenorphine taper. He was said to be stable off meds for 3 days, and he was downgraded to their residential recovery program. However, he very quickly redeveloped agitation and delirium, and he was then sent to our hospital, where in the ED, he was experiencing such severe agitation that they admitted him to the ICU, where he required a propofol, a Precedex, and a fentanyl drip and was intubated. So very severe withdrawal, which the ICU treated appropriately. And then I started seeing him when he was downgraded to my internal medicine team 1 day after the ICU. So at that time, we did a severe a high-dose phenobarbital taper for him. And with the assistance of our psychiatry colleagues, had him on 2 milligrams of buprenorphine 3 times a day. And he was intermittently struggling with significant withdrawal symptoms, even 3-4 days after downgrade from the ICU. We finally got his doses right, and he started feeling better on the 5th day. We had up titrated his Suboxone all the way up to 12 milligrams daily, and had done the phenobarb taper. And we had our substance use navigator see him, as well as our psychiatry colleagues. And we discharged him from the hospital on a Saturday with a follow-up at the medical addiction treatment clinic the following Monday. So pretty great follow-up to make sure that he had adequate care. And we discharged him with Suboxone 12 milligrams daily. A couple of considerations for this case and some questions that I had never experienced having to treat comorbid opioid use and benzodiazepine use withdrawal. So that was challenging to kind of differentiate where his symptoms were coming from, maybe which substance withdrawal and which medicine needed to be up titrated, the phenobarbital or the Suboxone. So that was a challenge, and our psychiatry colleagues helped us with that. And then another big piece that was more kind of along lines of the psychosocial aspect of this case is that this patient really had significant broken trust in the medical system because these medications had been prescribed by his primary care doctor initially without the proper education surrounding those meds. And so he was very hesitant to try new medications that may actually help him this time. And so myself and my psychiatry colleagues really had to reestablish that trust, which I think we did effectively because we had such a good psychiatry team and we have a really great medical addiction treatment outpatient facility, and our substance use navigators are fantastic. So we did have to rebuild that trust, but I think that really worked quite well with our system we have. But yeah, so my questions for this case are just optimal treatment of patients who have comorbid opioid and benzodiazepine use. And then what is sort of the best way to transition a patient like this to outpatient care when benzodiazepine withdrawal may last for weeks?
Thanks so much, Dr. Landis, for this great presentation. I open the floor to anyone on the call that has any follow-up questions or any insights they'd like to share.
Hmm. I'd like to say that, first of all, Dr. Landis, very, very well managed, on the inpatient side of things. So kudos to you guys for that. And then you kind of sort of answered, one of your main questions, what do you do afterwards, right? And you answered it yourself where, care coordination is one of the pillars of treatment for people with like multiple substance use disorders or with comorbid mental health conditions and substance use disorders. So yeah, good care coordination and navigation through the system is very important, especially for patients like these who have this distrust in the system, and rightly so, right? I think to your question about like how do you transition them to the outpatient setting? I wish there was like a one-liner answer, but there isn't. They just need to be transitioned to a place that has good care coordination in addition to all the other services that they require, like therapy and like medical management. But care coordination is something that would be vital in this particular case.
Yeah, awesome. Thank you. And I think we were really lucky to have support from our substance use navigators to make that happen.
And one other thing I really wanted to point out here, and that's generally where benzodiazepines and alcohol, they work the same. They kind of sort of share similar withdrawal profile. But one thing that differentiates benzos from alcohol is, a little bit, is that with alcohol, the withdrawals are more predictable. There's a pattern to how they happen. So you're going to have this first, that later, and then you have the risk of having seizure, or then you have the risk of having delirium tremens. And unfortunately, benzos don't follow that pattern. You're not experiencing much of an anxiety or anything like that, and all of a sudden you can be in delirium tremens afterwards. And that's kind of sort of, I think, what happened with this patient. And it's unfortunate with benzodiazepines, you got to be a little more vigilant when you're doing supervised withdrawals. And I think something that might help in the post-acute, like withdrawal setting for benzodiazepines, is gabapentin. Uh, and that kind of sort of addresses some of the issues that people have when they're withdrawing from benzodiazepines, especially the anxiety part of things. But unfortunately, you're right, it's difficult to manage benzodiazepine withdrawal, especially with comorbid opioid use disorder. If they're on Suboxone, and like Suboxone is safe, but only when it's alone. But if you add another downer, then all of a sudden the risk calculus changes and you got to monitor it closely.
All great insights. Thank you.
And this is Alicia, Dr. Kowalczyk. I was going to say again, kudos for a great case and bringing this forward, because I often see opiates and benzos go hand in hand. So this is not uncommon in my practice, and it can be really challenging, as you experienced, particularly managing them in a lower level of care than an inpatient setting. So what happens afterwards? I wanted to say kudos for thinking about starting right away something to address anxiety, whether there's pre-existing anxiety disorder, or they're just getting that rebound from coming off of the benzo fairly abruptly. So gabapentin was a great choice, as we just heard. The other thing I would think about adding, just because it takes a while for it to kick in and to get titrated up to effective dosage, would be SSRI or SNRI. That could be started and continued and titrated outpatient, either in conjunction with the gabapentin staying on board long term, or, not, as they get stable on the other agent. There's also, I think, a mention that this person has a history or active depression. So again, another indication for one of those medications to think about. And then just the choice of phenobarb can be a really nice choice, because it does take a long time once somebody's therapeutic on it to kind of leave the body. So it kind of auto tapers. So you can take advantage of that sometimes. So that was I think a really great decision.
Thank you.
Thanks, Dr. Kowalczyk. Sandra Flores, I see you shared a comment in the chat. I was wondering if you could unmute and elaborate on that, please.
Hi, it was a great presentation. We do outpatient treatment for opioid use disorder. We use methadone and buprenorphine. We have a lot of patients that come in and they have the comorbid diagnosis. And with our patients, we try to work with their PCPs to slowly taper them off the benzos. And we've had a lot of people that have successfully done that because the benzos have such a long half-life. That's one of the reasons why that you see the withdrawal later, like she was talking about, and the other doctor. But we've had great success with both medications and people tapering off of their benzos. But a lot of the inpatient treatment facilities do not allow them to continue that protocol. And that's unfortunate. Here in Abilene, we have a treatment facility here. When they go inpatient treatment, they'll start them on the protocol. And if they're already in a clinic, they will allow them to continue to be medicated with buprenorphine or the methadone, or they'll bring them over to our clinic and we can admit them and start the process here. And the treatment facility brings them over daily to our clinic.
Awesome. Thank you.
Thank you, Sandra, for sharing your experience with a similar situation. And Brooks, Dr. Landis did share, great case, Laura. Managing withdrawal inpatient from multiple substances can be a real challenge. And then layering delirium from other cases like prolonged ICU stay makes it even tougher. So kudos from Brooks for you, Dr. Landis. Are there any other questions or comments from the audience? Dr. Kowalczyk.
Yeah, I was just going to say something else to follow up outpatient that often comes up with folks, either with both opiate and benzo use disorder early in recovery, or one or the other, but particularly benzo use disorder is insomnia. And so particular attention to sleep hygiene and making sure that's on the checklist that Monday of, so how are you sleeping? And making sure that's getting addressed as well, because that can trip up recovery pretty easily.
Thanks, Dr. Kowalczyk. And I do see that some folks on the call were having some challenges with their certificates. So just as a side note, if you are experiencing that, please reach out to Jasmine, our coordinator, and she would be happy to address those situations via email. But any other thoughts or comments, resources, perhaps similar experiences from others on the call that they can share with us? Oh, Dr. Waklu, I see your hand is raised. Go ahead.
Dr. Landis, that was a great presentation, and the management was fantastic. And like Dr. Chaudhary said, sometimes benzodiazepines withdrawal can have such a after acute withdrawal treatment, the course can be so complicated. I've had withdrawal seizures as late as day 17, day 21 on people taking high dose alprazolam. So this was great the way you managed it, and then with phenobarbital and then send them home on gabapentin. That was a great cover and fantastic. It was a great case.
Thank you. I appreciate it. Yeah, I mean, it was day 17 and he was still, borderline DT. So yeah, thank you.
Dr. Walker.
Yeah, the only thing I was going to say was, on the acute side of things, not necessarily this case, but just in general, it's the benzo or alcohol withdrawal that's going to be the really complicated and probably more dangerous situation. And so, at least in our in our situation, but always thinking about this in our hospital system, it's sort of like if you can rapidly stabilize the opioid withdrawal to try to keep things more clear. And also just realize that a lot of times your symptom-based scoring, like CWAs, are confounded potentially if you don't have that opioid withdrawal under good control. It can be really, really complicated and tricky. It sounded like y'all did a good job with him, and it was really hard.
Do you think even going up to higher doses of Suboxone earlier would have been maybe warranted? Because it was just like 2
Definitely.
TID, but and then we kept getting confused. Is it opioid? Is it benzos? Do we need morphino? So, okay, so earlier buprenorphine, higher doses. Yeah, okay.
I mean, I will say when I saw that, and I saw a lot of people also shaking their heads, when I saw that dose, I went, oh, that's a pretty low dose for somebody with this much of complication and struggle that, you can definitely be more aggressive. I thought that you were saying 12 TID there for a second. Oh, okay.
Yeah, started at 2
Oh.
TID, and then we realized quickly, probably there was a delay in getting him optimal treatment for his opioid withdrawals. Yeah, probably.
And the beautiful part about buprenorphine is that it has like a ceiling effect to it. So like, you really need to have them on like a small dose to ensure they don't go into precipitated withdrawal. And once that safety is established, like, ramp up should be fairly quick.
Yeah, awesome. Thank you.
Dr. Landis, you just proved a really great point in my mind. Do you have any other questions for our experts? Because it's always like, does the audience have questions for the hub or whatever? But if you think of anything too, please don't feel free to ask them, about the case or not, or the field. They're a wealth of knowledge. So, Dr. Ramesh wrote earlier in aggressive bupe titration is safe when the patient's drug of choice has predictable half-life pharmacology, i.e. hydrocodone and oxycodone. I don't know if Dr. Ramesh, you wanted to add anything else. Sorry, I just feel like I'm a parrot reading that, but if there's any other details that you'd like to add.
Oh, that's helpful. Thank you, Dr. Ramesh. She's actually my attending right now, so I'll talk to her about it.
Great. Well, Dr. Chowdhury, I will pass the mic to you for a summary of today's discussion, recommendations, and case for all of us today. Please, thank you.
Thank you so much. So first of all, thank you, Dr. Walker, for this amazing presentation today. It's a very, it's a topic that every one of us has to deal with when we're in the inpatient setting. So we talked about how do you deal with pain control with people with opioid use disorders. And Dr. Walker went through the first line treatments for opioid use disorder, which included methadone and Suboxone and then naltrexone, and how do you manage these medications while you're doing pain control. And the first thing and the most important thing that she talked about was some of the myths that are surrounding pain control for people with opioid use disorders. One of which is that you can't give them full agonist opioids, or if they are on Suboxone or methadone, full agonist opioids will not have any impact. That's an important one that we definitely need to keep an eye on, because people can be on methadone and Suboxone and have full agonist opioids on top of that for pain control. The other thing is you can use these medications themselves, including Suboxone and methadone, for pain control, but they have their limitations. And if the patient is in severe pain, you still might need full agonist opioids to be given on top of it. And then Dr. Walker also talked about sometimes with severe cases, there might be a need to down titrate Suboxone a little bit, but the idea is to keep a small dose going on so that you don't have to go through the induction process of Suboxone all over again. Um, and the dosage of full agonist opioid should be dictated by a patient-centered approach and an eye on pain control, and not based on how difficult down titration and discharge planning is going to be after uh, the appropriate pain control has been achieved. So I think those are all important things, especially in the case of naltrexone, where it's a it's an antagonist, it's a mu antagonist. Pain control becomes a little tricky because these patients have lost all their tolerance to opioids. So the important consideration would be to keep an eye on what doses you give the full agonist opioids on. Whereas in the case of naltrexone, you want to be safe about what dose of full agonist opioids you're giving for pain control. In the case of buprenorphine and methadone, you want to be more liberal about the dosing of full agonist opioids because they already have a competing mu agonist or partial agonist sitting on the receptors. So you want to give them higher doses than you would give to opioid naive patients to achieve the same level of pain control. So that's the summary of Dr. Walker's presentation. And then in addition to that, there are other methodologies. So multimodal pain management should never be ignored. So yes, there is always the benefit from the Tylenol, the extra dose of Tylenol, the extra dose of ibuprofen to take the edge off. And finally, we have some newer treatment options, which include ketamine, for example, which can be really helpful for the severe cases in the perioperative period. Now coming to Dr. Landis's case, first of all, thank you so much for presenting that. This was a very interesting case and one that we see very often these days. And you guys did a very good job at managing it. The important points that came out of this presentation are, one, first of all, the withdrawals from benzodiazepines can be tricky. They're not as straightforward as alcohol withdrawals are. So you might have a different course of like an unpredictable course of withdrawal as compared to where you have alcohol withdrawals. You can monitor with SIVA, and you will have these things like build up in a pattern. In the case of benzodiazepines, you can all of a sudden have a breakthrough seizure, or you can have delirium tremens after a set amount of time. The other important thing that came out of this is that managing the some of the symptoms of benzodiazepine withdrawals at the time of discharge become very important when you're dealing with comorbid opioid use disorder. So managing the anxiety that's associated with opioid withdrawal and the insomnia that's associated, benzodiazepine withdrawal and the insomnia that's associated with benzodiazepine withdrawal becomes important. Unfortunately, we don't have medications for benzodiazepine use disorder, so a taper of benzodiazepine is what needs to be done. And some medications that can help for the post-acute phase can be gabapentin and SSRIs. And in the acute phase, phenobarb can be a good medication just because if you achieve the therapeutic doses, it can self-taper. So that was my long-winded summary of today's presentation and case.
Thank you for that awesome summary, Dr. Chowdhury. That was perfect. Huge thank you to everyone that attended today's session, in particular our wonderful presenters, Dr. Walker and Dr. Landis. We are very grateful for you all. And as a reminder to everyone, to claim your CME credit, you must text by midnight tonight. Text attend 10100-862 to 844-502-1338. If you're having issues, please do reach out to Jasmine. She would be happy to assist in getting all of that CE situation straightened out. And we do kindly ask everyone to complete the post-session feedback survey using the link that Karen shared just a little while ago in the chat. We look forward to seeing everyone at our next Echo session on September 11th. Have a great rest of your week. Thank you, everyone.